Hi, good afternoon, and welcome to the CMH Family Medicine Top Tips and Tutorials. I'm Dr. Madeleine Muller, and this is the last little episode in our series on mental health schizophrenia. So we've just looked at how do we manage the schizophrenic patient when they present in acute psychosis. So now you've got your patient, you might have actually treated and managed your acute psychosis, but now you actually have to treat and manage their chronic psychosis. So this is somebody where you've made the diagnosis, you've used your DSM-5, and you've decided this patient has schizophrenia. So starting off, very important from the very beginning, the whole MDT needs to be involved. So schizophrenia is an illness that affects every aspect of this patient's life and is going to have a massive effect on the rest of his life and has huge impacts on his family and his social scenarios. The social worker is absolutely key to have involved. And if you have a psychologist or counseling services available, as a diagnosis, it's going to be a very devastating diagnosis for the patient and the family. It's great if we had community-based mental health nurses. Where were all our wonderful mental health nurses? Because it'd actually be amazing to have somebody who's regularly popping into the household and providing support. And then don't forget our occupational support team. So our occupational therapists can be very helpful for both vocational rehabilitation as well as functional rehabilitation. So remember, psychosis affects your ability to just cognitively manage life. And our OT can help people structure their life in a way and help them to sort of pull things together. Very important to involve the family and the carers. They're going to need to provide the structure and quite often the physical and support care that this patient's going to need. Quite often the patients are not going to be able to work. If you've got patients who've got quite marked negative symptoms and are not really able to take care of themselves, you might even be able to justify a care dependency grant for somebody to always be around. And the family needs to identify when that patient is relapsing because the patient is not going to have insight. So we need to train the patients, the family up in the symptoms to look out for. And we need to be able to help our patients reintegrate back into the community once something like this has happened. So usually by the time they come to us, you might have a few years where they're the guy who's been wandering down the road or sitting at the intersection. And actually, once we've managed to address some of their mental health state and help them to come out of psychosis, how do we help them to actually integrate back into community? So probably the most important thing you need to do for your schizophrenic patient, and this is the thing we are the worst at, is psychoeducation. We need to teach our patient about what all this means. And it's very uncommon where the patient comes in, or even the family where the patient comes in and says, "Hi, I'm here, I have schizophrenia." Like you would have a patient saying, "Oh, I've got diabetes," or "I have hypertension." A lot of patients don't know the word, they don't know what the word means, and they don't understand what this illness is. So they need to be able to, once the psychosis have come down, and the family and the patient needs to understand this is a chronic condition. It can progress. We need to look at how we stabilize this, and we need to destigmatize it as a, the crazy sort of trope that tends to be used, and to really see this as a physical illness that's just affecting his mental health. Patients need to understand that the treatment is lifelong, that there are different options. So if something doesn't agree, we can try something else. And we have to talk about the side effects. Or if your patient is prepared, there's less likely that they're going to stop the treatment the first time of travel. And they need to understand about relapse. And we've even had patients where you sign a contract that they know if they go off the rails, they will listen to, they'll have somebody they trust. And if that patient says they have to go in, they will listen to that patient and go in. We have to talk about the impact on life, how it can affect work and relationships and help them cope with those particular things. And very much to look at issues of self-esteem and confidence. Again, because it takes them years by the time they come, they're usually not able to maintain a work or relationship, and they might see themselves as somehow deficient or less than others. And that's where counseling and psychology can be very, very useful. There also needs to be a particular trauma focus. So things happen while people are psychotic. Things happen to them, but they also do things that they later regret. And there are severe stories, and that's very uncommon, but there are stories, for example, of somebody while psychotic, for example, killing his mom, and then coming out of the psychosis and have to deal with this thing that had happened while he was psychotic. It can have a massive effect on mental health for all of these reasons. And so they're definitely also at a higher risk of depression, higher risk of anxiety, higher risk of suicide. These things need to be talked about. And so this psychoeducation for me is absolutely key as part of our management of schizophrenia. It needs to be ongoing through every appointment. We have to have these conversations. And that's very different. So in diabetes, you're talking about what they eat. But with a patient with schizophrenia, we're talking about what's happening with their life and their and things like depression and coping mechanisms. So let's just look at the treatment. So there's levels, level 1, 2, 3. Level 1 treatment, that's when you initiate, and you've got two choices. So you're either going to give your patient haloperidol or you're going to give your patient risperidone. So haloperidol as a long-term, as an option, we quite like that if you're going to have somebody now on treatment for life for schizophrenia, just because the risperidone is not so great from a metabolic point of view. So if you're on risperidone for life, you're going to pick up weight, you're going to develop potentially a higher risk of developing diabetes. And so that's a little bit the risk of risperidone long-term. So therefore haloperidol is often used. But haloperidol, especially in our young men, higher risk of tardive dyskinesia, extrapyramidal side effects, that horrible acute dystonias that the young men get. So generally in our older population, we tend to use haloperidol. If you need a bit more sedation, you'll use the haloperidol. If you've got a young man, you will definitely use risperidone as your first choice. And then your chlorpromazine, we generally don't like using in our setting unless you're going to use it for a short period of time because it is so sedating. And you can see the dosing there will depend a bit on the size and the fragility of your patient. Haloperidol, you can see low dosages, somewhere between 0.75 milligrams to 1.5. You'll give at night. It'll help them sleep a bit better. And the risperidone also 2 to 4 milligrams at night. So let's say the response was not very good to either of those, or you can't use it. So haloperidol or risperidone, for whatever reason, is not an option, or they've not responded well to it, then olanzapine is going to be your next option. That you would start at 5 milligrams, and you can increase that to 10 milligrams, also giving it at night, with a maximum of 20 milligrams at night. This can be quite sedating, and also a lot of those very metabolic effects we talked about earlier. If a patient did not respond to haloperidol, risperidone, and then does not respond to olanzapine, then clozapine is what we use for resistant schizophrenia, and that will only happen under the specialist care. And so there is a level 4, and apparently in the tertiary and quaternary care, there's something called amisulpride. We don't have access to that, and that will be decided through your psychiatrist. So let's say you started your patient on haloperidol or risperidone, and now how do we follow that up and what do we do with the treatment? So we actually want to see the patient quite quickly just to see how they're all managing, but you're going to only adjust your medication after 3 to 6 weeks. So it takes a while for the medication to work really well. So haloperidol, you started on that low dose, and you can increase it slowly until you get to about 5 milligrams maximum, and you're going to use clinical response. So if they're responding well to 2 milligrams, you don't have to go over 2 milligrams. If the patient's responded well to haloperidol and it's managing quite nicely and they quite like the idea of just having a once-a-month injection, then you've got clopixol or Dapixol as your two options. And remember that clopixol quite sedating, so more for your aggressive patients. A little bit of depression, then you might use your Dapixol, the flupentixol. If you decided to start on risperidone, again, you've started on that 2 to 4 milligrams. Your maximum dose is 6 milligrams per day. And again, you're going to titrate it according to that response. And chlorpromazine, as I said, not a big fan, but you might use that for short periods of time. So when do you send off to the psychiatrist? So the majority of patients we can actually manage on our own. And when we talk about referral pathways, it's actually already our families and our communities need to understand when to actually send patients in to get help. But we ourselves will refer to psychiatry if the patient is at a high risk to themselves or to somebody else at any time, if you're not sure about the diagnosis, or if they're resistant to the treatment that you're giving them. Very important, when you refer a patient, please write a really good referral letter. So quite often our psychiatric hospitals, psychiatrists are quite far away. You might send the patient off in an ambulance to your psychiatric hospital 2 hours away, and quite often the family is not going with. And the patients obviously are extremely poor historians. So being able to put all of that in a letter, all of their past medical history, but also their social context, their all the history in terms of substance, physical, all blood, extra, everything in that referral letter. And it's a bit similar to when you refer somebody with diabetes, you're going to refer them with all their blood and kidney results. When you refer somebody with schizophrenia, you refer them with a very good history letter on the history of that patient. For those patients who's had a poor response to treatment, please, obviously adherence is usually the biggest issue. So you can't ask the patient if they're taking their treatment well. You're going to have to check with the family, and you're going to have to talk about dotting. So dotting means actually looking in the mouth and making sure they've swallowed the tablet. That's direct observation of treatment. And if there's poor adherence, there's usually 3 things you need to just double check. It might be the illness, so maybe the patient's going psychotic and that's why they're not taking the treatment. It might be that they've got side effect on the medication and that's why they're not taking it. Or it might be the patient just doesn't see the point. And so you'll have to manage the situation accordingly. So obviously if the medication is causing the problem, change it to something else. If the patient just doesn't see the point or keeps on forgetting, obviously, maybe the depot antipsychotics are quite nice, and be sure to address underlying psychosocial factors and substance abuse that might be contributing. They do have in the EML that you can consider placement to a residential home or a daycare or a sheltered employment workshop. Chat to your social worker. We have very few options of those, but there might be something that a local NGO is doing, and it's good to look out for that. And certainly these patients do qualify for permanent grants. So if they do manage to have a little job that they're holding down, excellent. But if they're really struggling to engage in the work market, I think this is a good reason for a permanent grant. And if they need somebody to be around all the time because they're not quite able to look after themselves, then a care dependency grant for that person. So just in final few things on follow-up visits. Every visit you see the patient, we've got that tool I talked about called the BPRS in our assessment that gives us an idea of how a patient has responded to treatment. And you can ask the patient first, are they staying? Are things the same? Are they getting better? Are they getting worse? And then go through all the different symptoms to see how they're doing. And so we want to try and minimize the symptoms, but you might have to understand that you might not reach a place where the patient's going to be symptom-free. And you have to see what can the patient tolerate, what can the patient live with. So in the EML, doctors are supposed to see the patients every 6 months. So nurses can monitor, but nurses can't actually do that 6-monthly script. Very important to look out for your EPSIs, any early signs that they might be developing extrapyramidal side effects, and then you're going to adjust your treatment according to the response, adverse effects, and comorbidity, obviously. Also to look up, apart from your psychoeducation, is just to remember that our patients are more at risk of, especially metabolic disorders. You might have to involve a dietitian actually. Treat those comorbid mood disorders if they've got depression or anxiety. But remember to screen them: hypertension, diabetes, dyslipidemia. Keep an eye on things like waist circumferences and BMI. And obviously, if you do diagnose, we have to manage those very well. Quite difficult is that substance use is often accompanies schizophrenia, partly as a way to also cope, and also because judgment is not quite as good as it could be. And you can, for example, involve your occupational therapists in terms of ways to help them manage. So that hope has given you a bit of an idea of how we can better manage our patients with schizophrenia, make a diagnosis, educate your patient and the family. The treatment is actually not very complicated and works fairly okay, and provide the necessary MD team to provide good care for our patients in the communities.